Hello. Hello. Those who are in the Zoom, can you hear me? Hello, doctors. Welcome everyone to First Aid AMC Clinical. Sorry for the late today. It's actually having some problem with the sound system. So, do you guys still hearing me well, or is there any difficulty hearing? Those who are in the Facebook, just let me know if you guys are hearing well or not. Sorry for the late today. It's actually having some problem with the sound system. So, do you guys Okay, guys, so let's start today's session. Before we start today's session, let me introduce myself. I am Dr. Arshan Ahmed, and we're running a new course online that I think all of you know that is the First Aid AMC Clinical. We also run courses for MCQ and PESCI. So it's been an offline course so far, and we are based in Sydney. It's a registered AMC preparatory course. I know that many of you may not heard about us because it's been always offline, and we are not publishing ourselves a lot. Now, as there is the COVID situation going on at the moment. So, and there is isolation everywhere. So we think like it would be better if we can run an online course. And I think that is a great opportunity for all of you. You can, like many of you are not in Australia. Some of you are in other countries, maybe in Australia, but in other states. So for all of you, it's the online preparatory course are nowadays are very beneficial and less time consuming. So that's why we think that it's a better idea to start an online course. So before I start today's session, I want to know, first thing is first, those who are in the Zoom, you guys can hear me, right? And those who are in the Facebook, you guys can also hear me, right? So just make sure that I want to confirm that everyone is hearing well. Good. So, any of you are having any questions, you can ask me today. Dr. Asma, you think that the sound is too low? Is it low for everyone or just for someone else? Fine, great. Okay, so before we start about our today's session on psychiatry and cardiology, and if we get some time, we will also do some pediatrics today. But first thing first, you should always remember that what you are going for. Now, all of you has passed MCQ. It was not a bad or not a very hard for any one of you to pass, but AMC Clinical is one of the hardest exam that you will face in your life. Trust me, that's the true thing. Many people will say, no, it's really, really easy and you can pass it. But no, it's not that much easy. They filter you and they take the best out of you. So you have to show yourself and you have to sell yourself. It's a kind of like interview. You're in a room, there are 100 candidates for one job. You have to sell yourself. And how you can sell yourself? By becoming exceptional, and they will take you if you are exceptional. Now, many people or many students, they are exceptional by born, and many of us are not like too much exceptional, but with hard work and with good preparation, with materials, with some of the mentor or guidelines, we can be exceptional also. So that's why I know that many of you will never ever need any tutor or any mentor to pass this exam. And uh, in the same time, many of you will need that. Okay. When I started my preparation, I took help from people, I took help from mentors. It's nothing like we don't need that. We need a guideline because all of us, like some of us are Asian territories, some of us from Africa, some of us from Europe. So in our countries, that how we used to manage patient is totally different from how in Australia we manage patients. So if someone working in a general practice, someone working in a hospital in Australia, they know how to deal with the patient and they know the system here. And if you are under some of them, then you will be really, really lucky. So that's why we think that for AMC Clinical, most of you need some guideline to go through. And remember one thing, if you can go through some cases, which most of the time comes in the exam very frequently, like if you can prepare yourself 150, 200 cases, then there is not no new cases that can come in the exam. You are prepared, well prepared. Now you can go for exam. The next thing that, yes, you know that these are the cases that can come in the exam, but still you may not pass the exam. Why? Because the next important thing is how you prepare yourself and how is your approach. Your approach, your voice, your tone, your way of talking, and how polite you are, how empathic you are, that determines in your exam that if you are going to pass this exam or not. Trust me, they don't see how knowledgeable you are. They see how much empathic, how much polite, and how much standard you have to work in Australia. Obviously, to work in Australia, you have to have that standard. And it's normal, like when you will first time start preparation, you will stutter. You will stutter when you will discuss or when you will do role plays with your partners. You will stutter like a dumb boy or dumb girl. But trust me, just within 3 to 5 months preparation, you will talk like a real person, a real doctor. So it depends on how you are preparing, how much hard work you are doing. So it's a vital part for everything. Whatever exam you are going to face in your life, these things are always be the basic of your success. The next important thing, that AMC clinical exam, nowadays you know that it's been postponed, right? So it's many people, many students of us also waiting for their exam. But think in a positive way. It's a chance to make yourself more better. So you can prepare yourself more harder, more better. Now, when the exam will be open, and then you can be totally confident that, yes, I'm confident enough to go for the exam. So it's a positive thing that's happening, not a negative thing. AMC clinical exam, it usually, like it says 20 stations. Among 20 stations, 16 are real station, 4 stations are just a rest station. Among 16 stations, 2 stations are pilot, 14 will be a scored station. Among these 14 stations, from this year, if you can pass 10 out of 14 stations, you're passing that exam. There is no retest so far in this month, in this year, and so on. So you have to either pass or fail. So there is no retest from this year. I know that most of you know all of these things, but I'm just saying for the purpose, just any of you maybe just totally new, totally beginner, and you don't know anything about clinical. So it should be the first thing that you should know, that what can come in the exam. Remember, when you are going for the exam, and in the exam hall, there are some cadets or some medical students who will be over there, and they will receive you in the floor or in the ground floor. Then they will take you up through a lift. I'm just giving you a view so that this view will help you, and help you to adjust with the environment that will come when you will going for the exam, so that you don't feel that it's totally new for you. Okay, so you're going up through the lift, and you are thinking that, well, there are too many students and there are too many good people around me, so will I pass this exam? Trust me, guys, don't think anything about others. Think that you are the boss of yourself, and you are totally confident to go through this exam. Pass or fail, that depends, but you are going to finish the exam. Many candidates, after first or second station, they feel like, well, I'm not going to pass this exam, so whatever it is, I just do it and finish it exam. No, even if you do not do well in the first few stations, it doesn't mean that you are going to fail the exam. So that's important. Now you go up through the lift into the exam floor. They will check your ID. They will give you a badge in your neck so that you know that what station you are starting with. Then they will now you may need to wait for like 1 hour or more than 1 hour in the room to start the exam. That's okay. You can even sleep at that time. I have seen many people are sleeping, but I don't know, I could not just blink. So I was totally like, oh my God, what's happening? So it can happen to anyone. And many people will be sleeping in front of you, and you will think that how a person can sleep in the exam. Then they will give you a just a review of how this exam is going to happen. After that, you are going to enter into the exam hall, the main exam hall. Trust me, you will be trembling at that time. Then one by one, like if you are starting with number 20 stations, they will stand you in the number 20 room. So in that way, you will be standing in front of the room. In front of each of the station room, there will be a monitor where the question will appear. So with the first bell, your question appears, and they will give you 2 minutes to read that question. In that 2 minutes, what's the most important thing that you are going to do? First thing is read the question. Finish reading the question, and obviously read the task thoroughly. Don't you forget to remember what is your task in this exam or in this station. So remember that task. After reading it, what's the most important thing? Make sure you at least remember 5 to 10 differential diagnoses before you go into the exam room, where the patient and the examiner will be there. After the 2 minute is finished, then you go into the room. Examiner will be standing in front of the room, and they will greet you. So good morning, can I see your ID? So you'll show your ID, your name, and then examiner will say, well, welcome into the room. this is your patient, Sarah. You can start. Do you have any questions? So you can say, no, doctor, thank you so much. Then you go into the room in front of the patient, introduce yourself very nicely, sit down into the chair, then start your 8-minute time to deliver your task. It could be history, it could be physical examination from examiner, and it could be investigation, it could be management or differential diagnosis. After you have done that, so in this way, this will happen for 20 stations. Remember one thing, you may not do better in the initial few stations. It's totally normal because human brain needs some time to adjust with the situation. And in the initial few station, you will not do good. And examiner know that. So they don't usually bother if you do some minor mistakes in the initial station. But as the time go on, you will feel like you are okay with the environment and you are doing great. So that's the important thing. Maybe in the initial, you may not be doing great as you expected, but that should not low you down. Yes, Dr. Anusha. So when we read the question, in the 2 minute outside, there will be no piece of paper. But when you enter into the room, in the table, there will be a piece of paper and a pen to write down. See if you want to write down something. But I don't think it's a good idea because you don't have much time to write everything. So I would say forget about writing. Just if you remember, if you can write the name of the patient so that you don't utter the wrong name. Many times this happens because when we do the role play, we use John or Sarah or Mary. So this name. So sometimes the patient names like Elizabeth and you are calling her Sarah. So this thing can happen. So you can write the name of the patient so that you don't do these silly mistakes. No, you will not know what are the pilot station, and in the rest station there is nothing. Just there will be a room where you can drink water or you can just take rest. But pilot station, you will not know what is the pilot station, so no way to know. So that's your main scenario, how the exam is going to happen. Now, let's start today's session. We will discuss these things more in our next sessions and everything. So let's start the cardiology first. So today we have a plan to show you how we can take classes. Usually always I follow the clustered approach. Clustered approach means that in cardiology, we will make 4 or 5 clusters. Like we will make the cluster in a way so that that cluster format will help you to finish everything in a very concise and formative way. Like you will see how the palpitation cluster is made, and with one format you can actually go through about 5 or 6 questions that frequently can come in the exam. So that's usually the cluster wise approach. That's the best approach to prepare for AMC clinical exam. Let's start with the palpitation cluster. How the palpitation cluster is important for your exam. Just give me 1 second. Let me see if the people in Facebook can hear. Yep, they can hear. Good. Now, our cluster approach is based on, first of all, always making a list of differential diagnoses. And then in the format, we will discuss those differential diagnoses and how to ask those questions. So always guys, like before you enter into the exam, if you see that this is a palpitation question, this is a nervousness cluster, this is a chest pain cluster. So think the differential diagnosis at the time, and you don't need to remember everything. You just need to remember this differential diagnosis. For palpitation, sometimes also nervousness, anxiety, feeling unwell, all these things can be there in this cluster. So same cluster, palpitation, nervousness, feeling unwell, anxiety. So all this will be into the same cluster of palpitation. In palpitation, what are the differential? Most important is your CVS. So it could be ischemic heart disease, it could be myocardial infarction, it could be hypertension. Any arrhythmia can cause it, like SVT, atrial fibrillation, flutter, VF, VT, anything can cause palpitation. Valvular heart disease can also cause it. Now, in your exam, most important question is usually in palpitation cluster is this arrhythmia. We will discuss those in very few minutes. There are some CNS causes, but it's not very important. So in CNS, always remember 3 or 4 diagnoses: trauma, tumor, infection, stroke, or TIA. Always, like if you go for CNS, 4 causes will be always there: trauma, tumor, infection, stroke. But for a palpitation, it's not very important. You can ask it or keep it as a DD, but your most important is CVS and endocrine. For endocrine, what can cause palpitation? Hyperthyroid, hypoglycemia, pheochromocytoma. Next one is your anemia, anxiety disorder. Remember, anxiety disorder, panic attack, lifestyle stress, all of this can be a psychogenic cause of palpitation. It's a very important question to ask in the exam. Some patients who are in the menopausal age, they can also have palpitation, hot flush, sweating. So it's one of the DD. Excessive tea, coffee, recreational drug intake, excessive alcohol intake can cause it. Some medication can cause it. What is the most common medication that cause palpitation? Salbutamol. So any patient just having asthma or COPD exacerbation and they are taking salbutamol inhaler, that can cause palpitation. So these are the important differential diagnoses we have to remember. Now it's very easy to remember. How you can remember this thing? 2C, 2A, 2M. So how to remember? 2C, 2A, 2M. What is 2C? CVS CNS. What is 2A? Anemia, anxiety. What is 2M? Menopause medication. And also you can say that 2E. So if you remember in this way, let me see. 2C, CEA, M. Or there is a more easier way to remember is CAME, came, right? So 2C, 2A, 2M, 2E. So that's how you will remember the differential diagnosis of palpitation. All right. So 4C is your CVS CNS. 4A is anemia, anxiety. Also, you can keep alcohol. 2M, medication, menopause. 2E, endocrine, and excessive tea, coffee, recreational drugs. So it's pretty easy. If you can just remember 2 came, then you remember whole palpitation. Now, this is the format that you have to follow for your palpitation cluster. If you can just memorize or remember this format, all the palpitation cluster will fall into the same question. So your history, your task is take a history and do the physical examination from examiner or ask investigation from examiner and then explain it to the patient or do the different diagnosis and differential diagnosis. So your history will always be very, very, very well organized. Remember, your history makes sure that you are going to pass this exam or pass this station or not. So whenever you're starting a history, introduce very politely. So you can say, "Hi, John. This is Dr. Arshan, one of the doctor here. I'm really sorry to know that you are having this racing of your heart. How you are feeling at the moment. Please don't worry. Now that you are here, we are going to take care of you and you are going to be fine." So this is what? This is called reassuring a patient at the first time when you see a patient. And that's very, very important. Many candidates, they just start asking question, rushing into the question, rushing into finishing the task. No, if you do that, you may not pass the exam. And first time candidate usually do these things more than the recurrent exam taking candidates. So as you as you now know, most of you will be first time candidates. So make sure guys don't do that mistake so that you don't need to go to that same exam hall again and again. So first reassure the patient just like how I have done. And then this is a acute condition. Patient is having palpitation. So you have to make sure that this patient is vitally stable. So go to the, so what you will do, please don't worry. Now that you are here, you are going to be fine. We're going to take care of you. Now, as you are having the racing of your heart, I need to make sure that you are vitally stable for answering my questions. Please excuse me for a moment. I'm going to ask my examiner some question and I'm going to come back to you. So you're taking a time from the patient. That's the important or gentle approach that you can follow. Then go to the examiner. So not, you don't need to go to the examiner. So this is a round chair. So you will just round to the examiner and you don't need to stand up for that. You can sit and then you can ask the examiner that, examiner, I would like to know if my patient vitally stable for further history. Examiner will say yes, you can go on, or sometimes examiner can ask you that, what do you mean? If examiner asks you that what do you mean, then you have to ask, what do you mean by vitally stable? In vital, we actually ask for 5 things: blood pressure and pulse, respiratory rate, temperature, oxygen saturation. In a palpitation, what is the most important vital that you should ask? What do you think? Pulse. And in pulse, what is the most important thing? So you will ask, what is the blood pressure and pulse? Pulse rate and rhythm. That's the most important. Rhythm, is it regular or irregular? You should know from the examiner. So very important in the pulse to ask that, doctor, is, I would like to know the rate and rhythm also. So rhythm is very important because it may give you a very important clue that is it a atrial fibrillation or not. So after that, you come back to the patient and you start asking question. So thank you so much for waiting, John. I want to ask few questions about your racing of your heart. Are you comfortable enough? Yes, doctor. So tell me more about your racing of the heart. So always start with a open-ended question. Sometimes patient will open up and give you all the information that you wanted to know. Otherwise, you have to ask one by one. So you can ask, when did it start? What exactly were you doing? When did it start? Did it start suddenly or gradually? Now, is this the first time you are having this sort of palpitation or racing of your heart? If the patient say, no, doctor, I had this before also, you have to ask the previous episode details also. So how many episodes so far? What happened at that time? How long did each episode last? How did they stop? Did it stop spontaneously or did you need to get any treatment for that? So that's the previous episode you need to ask. Then anything makes it better, anything makes it worse. So that's your palpitation question. Sometimes in some people will say that you should ask the patient to show how they feel it on that. That means, can you please tap it on the table like this? But some of the patient or role player find it very annoying. I have heard from the people who are actually going for the exam and took the exam, some role player find it pretty annoying to do that. So it's not very important to ask a patient, can you show it to me? Like, can you tap it on the table? And it will kill some time also. So you don't need it to do that. So it's totally fine if you don't ask a patient to tap it on the table. After that, go for the, so this is your history of presenting complaint, right? So that is your, what is the presenting complaint of the patient? Palpitation. So you should ask detail of that. After that, you can ask some associated symptom with palpitation. What are the associated symptoms? Most important is feeling lightheadedness or dizziness, any chest pain, shortness of breath. Now, one by one, you can start asking differential diagnosis question. So you can start asking CVS related question. Like in the CVS, you can keep like any chest pain, shortness of breath, any excessive nausea, vomiting, or sweating. What you are doing with asking chest pain, shortness of breath, nausea, vomiting, you are ruling out ischemic heart disease or MI, because that's your one of the important differential diagnosis. Then go to the CNS question, any headache, any problem with vision or speech, any weakness in any part of the body. So that's your CNS cause. Go to the endocrine, hyperthyroidism, any recent change in your weather preference. Sometimes patient can ask you, what do you mean? So you should ask at that time, so do you feel hot or do you feel sweaty most of the time? Or you can ask more precisely, do you feel hot when the weather is totally cold? Or do you feel really hot and sweaty in like, you can ask, like if you want to ask precisely or detail, then you can ask like, do you feel really hot and sweaty when other people feel it cold? And usually better question is any recent change in weather preference. What is weather preference? Some hyperthyroid patient, they prefer cold environment because they feel really hot and sweaty. Sometimes if you ask weather preference, they can like make you confused with that, but there's the important question for hyperthyroidism. So do you feel really hot and sweaty when most of the people feel cold? That's, if they ask that, what do you mean by that, then you can ask. Otherwise, any recent change in weather preference, that's a good question. Any change in bowel habit or body weight. Remember, for each of the differential diagnosis, at least one or two question is all right. If you get in this question, yes doctor, I feel really hot and sweaty these days, then you have to ask all the hyperthyroidism symptom one by one. Otherwise, for differential diagnosis, just two question or even one question is fine. Then pheochromocytoma, any episodic headache, sweating, or flushing of the face, just one question is enough. Hyperthyroidism comes in the exam, and also arrhythmia comes in the exam. Hypoglycemia. For hypoglycemia, did you skip your meal today? Any history of diabetes? Anemia. Do you feel tired and fatigued these days? Just one question. Infection can cause sometimes the short of palpitation, because fever can cause tachycardia, right? So any recent flu-like illness or any fever, cough, runny nose? Just one question. Sometimes electrolyte imbalance can cause palpitation. So any recent vomiting, diarrhea. Then go to the SADMA. So do you smoke or drink alcohol? Any recreational drug intake? So what is SADMA? SADMA is a like lot of things, but SADMA means, always remember three things to ask: smoking, alcohol, medication, allergy, and sometimes diet you can ask, but it's not important. In SADMA, only thing important is smoking, alcohol, and you can ask about some recreational drugs. Any excessive tea, coffee intake. So you can ask like, do you drink tea or coffee? If yes, then how much a day? Any past medical history like diabetes, high blood pressure, or heart disease? Any family history of sudden cardiac death? Very important to ask, because some of the arrhythmia can be congenital. So we need to ask this question, any history of sudden cardiac death? Social history. Why it's important? Because your one of the DD is stress. So any stress at your home or at your work, any financial issues. Do you worry a lot about most of the trivial things? Why we are asking this? Or you can ask, are you an anxious personality? That's for anxiety disorder. Generalized anxiety disorder sometimes can come with palpitation. So that's why we are asking this question. If female patient, and it's like around 40-45 year, you should ask about the menopausal symptoms also. So see that we have asked most of the differential diagnosis. So we asked CNS, CVS, we asked endocrine, thyroid, pheochromocytoma, glucose. We asked 2A, anemia and anxiety disorder. We asked about medication, right? Also, we asked about menopause. We asked excess tea, coffee, alcohol. We asked about endocrine. And in E, another you can keep as electrolyte disorders. Okay, so that's how you finish your history. So you're starting with the history of presenting complaint, associated symptom up to this, and then you start asking your questions. So CVS, then you go for CNS here, then your other differential diagnosis one by one. Always finish your history with past medical history, family history, medication history, and before that, SADMA. That means smoking, alcohol, recreational drugs. So in your history, your format will be always like that. First, your history of presenting complaint, then associated symptom, then all the differential diagnosis one by one, then SADMA, past medical history, family history, and lastly, medication history. So format is same for any history. We usually will always follow the same format so that you guys don't get confused asking question. So it may seem to you that there is a lot of things to ask, but remember, with understanding the format, it doesn't take more than 4 minutes to take a history. But you have to practice to finish it within 3.5 minutes for the exam. Clear, everyone? Now go for your physical examination from examiner. Physical examination for cardiology, always the same format. So start with the general appearance. So what you will do in here, after taking the history, finishing the history, you will say, thank you so much for your answers. Now I'm going to go to my examiner and then I will come back to you within a minute. Dear examiner, I would like to do the physical examination of my patient. I would like to know the general appearance of my patient. Most of the time examiners say, as you can see. I would like to know if there is any pallor, icterus, any clubbing, any dehydration. Now the pickled is a lot of things in the physical examination like pallor, icterus, cyanosis, clubbing, lymph node, edema, dehydration, but it's a generalized thing. You don't need to ask everything. Based on CVS, for CVS, only thing important is your pallor. So any pallor, no. I would like to know the vitals of my patient, blood pressure, pulse, respiratory rate, oxygen saturation. Also BMI. I always keep the vitals and BMI same because in many exam cases, BMI is important. And usually if you don't keep it as a format, you will forget to ask it in the exam. So general appearance, pickled, vitals, and BMI. Then you start your CVS related examination. First of all, start with the neck. In the neck, any raised JVP, any carotid bruit. I would like to do the focused cardiovascular examination. On inspection, any visible cardiac impulse. On palpation, is the apex beat normal in position? Any palpable thrill, any paraesternal heave, or palpable P2? So you have to ask one by one to the examiner, and examiner will give you the finding. On auscultation, apart from S1, S2, is there any added sound like any murmur? So this is the format of CVS examination, which is the most important in a palpitation cluster. Then I would like to do central nervous system examination, including the cranial nerve. Examiner most of the time will say it's normal. I would like to do other system like abdomen. Okay, like abdomen. Most of the time examiner will say skip. So you other system is respiratory system and also abdomen or GIT. So you can just say, doc. Now remember, many people or many course will teach you in a way that you need to ask from the head, then go to the toe. No, you should always in the exam do the focused physical examination. Focused means if it's a CVS case, you should do the CVS first. If it's an abdominal pain case, you should start with the abdomen first. And then just say that, doctor, I would like to do the other system as well, like abdomen, respiratory system, and the cranial nerve, and the central nervous system. Most of the time, examiner will say skip because they know you don't have that much time to do all the examination. And always physical examination finish with office test. So, doctor, is there any office test available like urine dipstick, blood sugar level, and ECG? For a palpitation cluster, ECG is a vital thing to ask. So that is our format of palpitation. So you know how to ask history. Now you know how to ask the physical examination from examiner. The next thing, we are going to do some cases that can come in the exam related to palpitation cluster. Now you will see how easy it becomes. You don't need to ask anything. Already we have done all the exam cases. You will see now. Your first question, you are a junior HMO in emergency. A man comes up with thumping or racing heart and giddiness started today. Take history, physical examination from examiner, ask investigation from examiner, explain diagnosis to the patient. What are the positive points in the history? Your history will be same like how we have done. All right. And then you may get this positive finding like patient is having palpitation, lightheadedness since 2 hours, also having some shortness of breath. She had these episodes 3 times before, started suddenly, lasted 2 hours, and then stopped all on a sudden. He also takes 6 to 8 cups of coffee a day. So you have got your risk factor. Sometimes supraventricular tachycardia can occur due to excessive tea, coffee intake. No smoking alcohol, no other history. Patient also anxious personality. He has some stress also. So you get your differential diagnosis. One is anxiety disorder. One is excessive tea, coffee intake. Another, you will get SVT in the ECG. So your positive points are important to find out because these are your key steps. Nowadays in the exam, they pass or fail you based on the key steps. There is no critical error in the exam. Previously it was, or also if you go through the handbook, you will see they write critical error. But nowadays there is no critical error. They will short out 5 or 6 key steps for a case. And if you can find those out, usually you can pass the exam. So these are the key steps or key things that you are finding out. If you don't ask appropriate question, you will not get it. Now look at this ECG, what you can see. Your next thing, like you first ask the history, then the PFE. Your number C task is to ask investigation from examiner. What investigation you will ask? Obviously, you will ask the ECG from the examiner. And when you ask ECG, they will give it to you. When you look into the ECG, what you should look at the first thing, always look at this lead 2, which is the most important because it will give you an idea about the rhythm. It also called as a rhythm history. Now, if you see in here, so this is I guess all of you know how to read the ECG, at least the normal basic thing. So this is the R wave, right? And this is also R wave. And if you can see, these are regular R wave. All are regular. And you can see there is a tachycardia because how to find out what is the rate of this ECG? Rate, if you want to find out, then always remember 300 divided by number of large square in between two RR interval. So this is one R, this is one R. In between this RR interval, there is, like, you can say more than one small square. You can keep it as like one small square. Okay, so what will be your heart rate? Usually this heart rate will be around 250. If you don't need to be totally specific in the exam, you can say about 250 or around 250. If there is two large square, then what will be your heart rate? Two large square, usually 150 will be your heart rate. If there is three large square, then is 100. If there is four large square, then 75. So you just need to remember this 300, 150, 100, 75, so that in the exam, you don't need to calculate the rate. So it will kill your time, and trust me, you will not have this much time. So just remember that if I get two large square in between two RR interval, then the heart rate will be 150. So you are looking at rate, you are looking at rhythm. Rhythm is regular, you can see. Then the next thing you look at is the P wave. And if you look at the P wave, there is no P wave in this rhythm strip. So absence of P wave. After P wave, look at the QRS complex. You can see the QRS complex is very narrow. In a normal patient, QRS complex should be between 1 to 3 small square. But in here, it's like less than 1 small square, which we call narrow complex tachycardia. So you can say that QRS complex is narrow. After QRS complex, you look at the ST wave. This is the ST wave. Sometimes there will be ST elevation, like your ST wave will come here. So that is usually ischemia or myocardial infarction, ECG. But in here, your ST wave is fine. Then look at the T wave. So T wave is also normal size and shape. And lastly, that you look at is the QT interval. QT interval is, if you start from the Q wave, so this is your Q wave, and finish of the T wave, that is your QT interval. So starting of the Q wave and finishing of the T wave, how much small square you have to count. Normally it should be 8 to 11. In here it's like 8 or 9 small square is here, so it's a normal QT interval. So it should be always organized way how you are explaining ECG to the examiner, because your task will be explain ECG to the examiner also. All right, now if you go, this is more appropriate. You can see that there is no P wave, there is only T wave, and there is narrow complex tachycardia here. So this is how the SVT looks like. How to explain ECG to the examiner? You will say, Doctor, I would like to describe the 12-lead ECG of my patient, John, a 25-year-old gentleman who came with sudden onset palpitation and giddiness. The ECG shows heart rate, whatever is the heart rate, you will say. In here it was 250, so say it as a 250. So heart rate 250 per minute, regular in rhythm. Then you start with the P wave, absence of P wave, narrowed QRS complex, no ST wave changes, T wave normal in size and shape, and QT on interval normal as well. So from the ECG, I suspect it could be a case of supraventricular tachycardia. So this is how you should explain ECG to the examiner. Very important to follow a format. Otherwise, you will find out that you are just stuttering in front of the examiner. But if you follow it, it will be pretty easy, and examiner will be very happy with your explanation. The next task will be explain the ECG to the patient. Now, you are not going to explain what is P wave, Q wave to a patient. Even we don't know very well how these things are, right? So a patient doesn't bother how this ECG looks like, what is the P wave. And a patient who is having racing of the heart, they will not even look at what's going on in the ECG. What you should do, you have to be very, very normal with a patient. When you explain this sort of hard thing to the patient, don't use any medical jargon. Remember, guys, if you use medical jargon in explanation, they don't like it. Most likely, you will fail that station. So, total no no word will be related to medical. You can use, like you will use supraventricular tachycardia, whatever medical jargon you are going to use, you have to explain it. So say that, well, thank you so much for all the information and your cooperation, John. Now I want you to see this ECG, now I want you to look at this paper. This paper, what we call it as a electrocardiogram, or in short ECG. This is the electrical record of your heart. Remember, the nurse was putting on some leads on your chest, and that is the time when we have got your ECG. The lines that you can see here are the result of the electrical impulse that conducts in your heart and helps your blood to flow all over your body. Let me draw a picture for your better understanding. This is your heart. So you will draw a nice and easy picture. Now this is your heart. The electrical impulses originate from here and then goes all over your heart to pump the blood into your body. In your case, there is some abnormality in this electrical impulse causing your heart to beat faster than normal. And that's why, as your heart is beating faster, you are having this racing of your heart. And as the heart is not getting enough time to fill in, your brain is not getting enough blood, and that's why you're feeling lightheadedness. We call this condition as a supraventricular tachycardia. I'm really sorry for the medical jargon. This condition can be due to other reason as well, like if you have any structural heart disease, if you have any problem with the valve of the heart, any medication, recreational drug intake, thyroid problem, infection, salt imbalance, excessive tea coffee intake, all these things can cause the similar kind of problem. So what you have to do in here, this will be obviously a diagnosis and differential diagnosis. So you will diagnose, your diagnosis will be supraventricular tachycardia. You have to explain a little bit about what is supraventricular tachycardia, and then you have to give all the differential diagnosis. So when you give differential diagnosis, make sure you show to the examiner that how you are ruling out the other DD. How you're going to do that? So most likely this is supraventricular tachycardia, but it could be due to other condition as well. Like it could be ischemic heart disease, but your ECG doesn't seem like that, and you don't have any chest pain or shortness of breath. It could be any condition related to your hormone like thyroid dysfunction, but you don't have any weather preference, no change of weight or bowel habit, so it's unlikely. Could be some tumor in your adrenal gland called pheochromocytoma, but you don't have any episodic headache, flushing faces, or also you don't have any high blood pressure, so it's unlikely in your case. Could be related to any infection, but you don't have any fever. Also, it could be related to imbalance of salt and minerals, but you don't have any recent vomiting or diarrhea. Could be related to some medications, but you're not taking any medication, which can be related to that. Could be low blood sugar, but you don't have any diabetes, and also you did not skip your meal today. So all these are very unlikely in your case, and your ECG confirms our diagnosis. Please don't worry, you're in a safe hand, and we are going to treat you accordingly. You will be fine. So finish with reassurance again. When a task is differential diagnosis, don't go into the management. Okay, make sure you say the diagnosis and explain the differential diagnosis very well. How I have done, you should do the differential diagnosis in this way. They like how you explain differential diagnosis. It's a very important part to pass the exam. Next one is your atrial fibrillation. A middle-aged lady comes to the ED with sudden onset palpitation. Task is history, PFE, investigation from examiner, explain causes, complication of the condition. All right, before I go into this, do you have any questions so far, guys? Are you guys getting me? Is the class uh, interesting, or are you enjoying the class? Good. Okay. Now you go for the next question is atrial fibrillation. Usually this is also in, like, sometimes in the exam you will get this question, because these are very important cases. Always in the practice, we get it. We get this sort of patient always. So in the exam, it's also important. I don't know who asked this question, but what is the difference between supraventricular tachycardia and paroxysmal supraventricular tachycardia? Pretty same actually. Paroxysmal supraventricular tachycardia is a type of SVT. Like usually there are types of supraventricular tachycardia. Like some has paroxysmal, some have permanent, some have chronic. So paroxysmal means like some like episodic supraventricular tachycardia. This patient, the patient that we have discussed, this patient has paroxysmal because 3 episodes so far and it lasted for 2 hours. So it's kind of episodic SVT. But in the exam, don't bother with PSVT or other types. Just say SVT, that is fine. So the next question is your atrial fibrillation. Similar way, you have to take the history. Same, nothing changed from how we have made the format. PFE, same. Investigation from examiner, that is your ECG. So ask the ECG and you may get any of the ECG related to atrial fibrillation. So if you look at here, what do you find? Always look at the rhythm first, because that will give you an idea that is it a SVT or atrial fibrillation. If you look at the rhythm, you see this is RR interval. Now you already understand that this person is not having a regular rhythm. So irregular rhythm, most likely atrial fibrillation. Then you look at the rate. Remember, for a irregular heart rate, irregular heart rhythm, you don't need to bother with the heart rate. Don't say the heart rate because it will take a lot of time to find out the heart rate in an irregular rhythm patient. So you don't need to do that. If you look at here, there is no P wave in this ECG. There is just some fibrillatory F wave. The P wave is actually replaced by that fibrillatory F wave. See the fibrillatory wave? This is how the P wave is replaced by fibrillatory wave. QRS complex is a little narrow or normal, you can say. Others are all normal. So in here, how you're going to explain, doctor, I would like to describe the 12 lead ECG of my patient, Mr. John, came with sudden onset palpitation and giddiness. The ECG shows heart rate. Now in here, see that in exam, you have to be intelligent. It's not like that you don't know how to make or how to calculate heart rate. You know that, but you don't want to calculate it in the exam because you don't have much time. So what you have to do, you have to be very intelligent so that examiner doesn't understand what you are doing. This is fair game, all right? You have to be fair in here. So what we should do, like you can say the ECG shows heart rate is increased, irregular in rhythm, absence of P wave, which is replaced by fibrillatory F wave, narrowed QRS complex, no ST wave changes, T wave normal in size and shape, QT interval normal as well. So what I have done, I said heart rate is increased, and they are not going to fail me that if I say heart rate is increased. Okay, but if you want to find out the heart rate in here, you have to do a lot of things, and you don't have that time in the exam. So don't do that. Just say, I can see the heart rate is increased, rhythm is irregular, absence of P wave replaced by fibrillatory F wave, narrowed QRS complex, no ST wave changes, T wave normal, QT interval normal as well. Explain to the patient. When you explain any palpitation, like especially supraventricular tachycardia, atrial flutter, atrial fibrillation, the explanation are same because the mechanism is same. So you will just say the similar thing that you have said in the SVT, but just the diagnosis will be atrial fibrillation. Similar, because in atrial fibrillation also what happens that heart, the electrical impulse is irregular, or the heart is pumping irregularly and faster. And that's why you are having this racing of the heart. As you are having racing of the heart is not getting enough time to fill in, and that's why your brain is not getting enough blood and you're feeling dizzy. Same, many candidates will go in that way. You can see this is the ECG, this is the P wave, this is the QRS complex, and patient will not like that. Trust me, in exam, it doesn't mean how much knowledgeable you are. It means how understandable you are. Patient wants to know what's going on. And again, if you are saying everything in non-medical jargon and you are not connecting the patient's symptom with the condition that you are saying. Like in this case, you have explained what is atrial fibrillation, but you haven't said why the patient is having giddiness, why the patient having racing of the heart. You have to always connect patient's symptoms with the diagnosis. Like I said, because your heart is pumping or your heart rhythm is faster, you are having this racing of the heart, and your heart not getting enough time to fill in, brain is not getting enough blood, you are feeling dizzy. So now the patient will understand, oh, that's the reason I'm feeling this way. Any like information makes a patient understand better and makes a patient less anxious about their condition. And that's the vital thing for any of your practice. It's not in your exam, it's in your real life. You have to always follow this. A patient comes in your clinic, you are not just giving medication and say that, well, you will be fine. No, patient wants to know, every patient wants to know what's going on and why it's going on. With information, patient doesn't get anxious. Patient feels that, yes, I have the enough information and I know what to do. That's why in Australia, like in some of the countries, there will be like, to say that patient is having cancer, it's not a good practice in some countries, because then the patient will be very anxious, sad, depressed. But no, in Australia, we have to deliver the condition, even if it is last stage or end stage, to the patient first. With the patient consent, you can give information to other, but first patient should know everything. All right, I was just going in another direction. So you explain it to the patient. Your next question, if you look at this thing, explain causes and complication of the condition. So what is the cause of atrial fibrillation? There are 5 or 6 important causes which can lead to atrial fibrillation. One is, first is idiopathic or lone atrial fibrillation. That means no cause found. It's the most likely. Then hypertension or high blood pressure, ischemic heart disease or heart attack or coronary artery disease, valvular heart disease, Congenital heart disease. How you will say congenital? The heart defects you are born with. Hyperactive or overactive thyroid gland. So these 5 or 6 is the most important. What are those? Hypertension, ischemic heart disease, congenital heart disease, valvular heart disease, and hyperthyroidism. Others you can say if you have time, like excessive caffeine, tobacco, alcohol, some lung condition, viral infection, and stress. But these 5 or 6 is most important cause. In this patient, there can be anything positive. Most of the time they can give you that, yes, I have high blood pressure. So you can connect that, well, you have high blood pressure. Sometimes that can be a underlying cause of your atrial fibrillation that you are having at that time. The next task was to say the complication. What are the complications of atrial fibrillation? Most important are two. First is a stroke. So you will show your first drawing and you will say in atrial fibrillation, the chaotic rhythm may cause the blood to pool in your heart upper chamber. So you will draw the picture like this. You don't need to be a very good drawer. Like you don't need to draw a very good picture. Just this will be okay. So you will say that in atrial fibrillation, the chaotic rhythm can cause pooling of blood in your upper heart chamber and it can form clot. If a blood clot form, it can dislodge from your heart and it can travel to your brain. Or whatever, just you can draw some brain or something like that. If a blood clot form, it can dislodge from your heart, can travel to your brain and can block the blood flow to your brain, which we call a stroke. Another thing, in atrial fibrillation, it can weaken your heart muscle and it can lead to heart failure in which your heart cannot circulate or pump enough blood to meet your body's need. So these two are the most important complication of atrial fibrillation. But I want you to reassure that as we have found it earliest possible time, there are many ways we can prevent this complication. Please don't worry, you are here with us and we will treat your condition accordingly and you will be fine. So always finish with a good word, good reassurance. Okay, guys, so this was about our palpitation cluster. In palpitation cluster, remember, if you go into the first, for the exam, from arrhythmia or from the ECG, the important usually this supraventricular tachycardia, atrial fibrillation. I haven't seen any other things coming up. Sometimes they can give it to you that congenital QT syndrome, which we will discuss in syncope cluster in the class. So usually these are the ECG you need to know. Atrial fibrillation, atrial flutter, supraventricular tachycardia, and prolonged QT syndrome. Other one is like in chest pain, two ECG also come. One is myocardial infarction, MI, and also pericarditis. So that will be discussed in chest pain cluster. Okay. So, and from other, just I have seen hyperthyroidism sometimes comes as a palpitation. Menopause, I have seen once coming in the exam in that way, like having palpitation or feeling anxious. So usually if you remember, and coffee also sometimes comes. So coffee, menopause, hyperthyroidism, and from arrhythmia, SVT, AF, these two are most important. VT, doesn't come. No, Dr. Anusha, usually management doesn't come in these questions because this is a long task, like history, explain the ECG and the diagnosis differential. Already it's a like long task, so management usually doesn't come. But if it comes, it's pretty easy. You know, like for SVT, what you will do. First of all, you will try the conservative measures like Valsalva maneuver, or also sometimes carotid massage. You can just say in that way. For Like it depends on if a patient is stable or unstable. In the exam, most of the time they will be stable. So for a stable patient, Valsalva maneuver or carotid massage. If that doesn't help, then some medication that like adenosine we can use. We don't need to discuss the dose and how we are going to treat a patient. It's just the basic, like just an outline of the management. If like it depends, Dr. Dina, how you are going to keep the timing. If only two tasks, then 6 + 2 minutes. Like history, diagnosis, and differential. So 6 minute history, 2 minute differential diagnosis. If your exam comes as a three station, then like history, PEFE, diagnosis, and differential. Then 4 + 2 + 2. Or in my view, it's more better to keep a little time in the explanation. Like I would say 3.3 and a half +2, then 2.5 in that way. But the basic is 4 + 2 + 2. 4 minute history, 2 minute PFE, 2 minute explanation. But in the exam, it's pretty hard to follow everything. So always make sure you ask history within 3 or 3.5 minutes so that you can get some time in the management or in the explanation. So depending on how many tasks you are having, you have to make sure that I have four tasks in the exam. I will not take 4 minutes in asking history. I will try to finish it in 2.5 minutes. And examiner will understand because you are running out of time. That's why you are asking questions very frequently. That's okay. You can rush where there is 3 or 4 tasks. But in 2 tasks, you should not rush. You should ask every questions. So this was our palpitation cluster from cardiology. We will start psychiatry in 5 minutes time so that you guys just keep a little time, just close your eyes, make your brain forget about what you have learned from heart or palpitation so that you can keep some time for psychiatry. Psychiatry is important for your exam. So very important, I would say. We would discuss the basic of asking a psychosocial history and how to ask the mental status examination, which is MSc. And most of you will get MSc in the exam, either video or face to face. As it's a COVID situation, it's a good thing that most of you will get video in MSc. Okay, so video is easier than asking the questions face to face. All right, so let's take a 5 minute break and then we will start again. Thank you all. Okay, doctors. So let's start psychiatry. Just take 1 minute time, see that how Facebook guys are doing. All right. So start with the psychiatry. Psychiatry is one of the most important for your exam because in psychiatry they usually find a candidate that how good they are, how well they are in a situation when a doctor should be really calm, really confident. Psychiatry stations, the role player they give to you, they are really, really well trained and a very, very good actor. They might even make you crazy in the exam that whatever you are asking, they are not going to answer you anything. So it should be like you should be your best at the psychiatry station. First of all, most important that usually many candidates usually get in the exam is the MSc or mental status examination. MSc format is pretty clear, so we always follow this aseptic J3R in the exam. In the exam, when you enter into the room, there will be pen and paper. In MSc format or in MSc cases, write the aseptic J3R in the paper so that you don't miss any of this. So what is aseptic J3R? A for appearance and behavior, S for speech, E for emotion. Emotion we divide into mood and affect. P for perception, usually hallucination is perception. Thought form, thought content, insight, cognition, judgment, and then lastly 3R, risk, rapport, and reliability. So we have to follow this aseptic J3R in any MSc explanation. Let's discuss one by one what each of these things means. First of all, your appearance and behavior. In appearance, you look at the patient and also look at how the patient is behaving with you. So look at the patient, how the patient dressed up, is well groomed or not. So these are the things that we actually comment on. So he is dressed appropriate to the weather or not, well groomed or unkempt, cooperative or not, maintaining eye contact or not. Is there any abnormal body movement or posture? Like sometimes depressed patients sit in a stooped posture, so we need to find that out. Anxious patient will do frequent fidgeting or frequent restlessness in their body movement. Mania patient will be restless, agitated, talking loudly, excessively. Some schizophrenia patient or psychotic patient, you will see that they are sitting in the room, but they are looking at the ceiling or looking at some other parts of the room as if they are responding to some unseen stimuli. If that's they are showing, you should comment on that. That's the most important part in the MSc, that if you can see what the patient is trying to show. So you have to comment on the dress, well groomed or not, cooperative or not, maintaining eye contact or not. Depression patient will not maintain eye contact with you. So you have to comment on that. Then abnormal body movement or posture, that also you have to comment. That is your appearance and behavior. Next one is your speech. Speech, we divide it into rate, volume, and tone. Usually if how I am talking with you guys, that's a normal rate, volume, and tone. If I am talking in a very slow monotonous way, you have to comment on that. Like depression patient talks in slow monotonous speech. How? Like if you ask like how you are feeling today, patient may wait for some minute or some second to answer your question. Yeah, yeah, I'm feeling fine, I'm feeling low, like this. So it's a kind of slow, monotonous. It means talking in giving a pause in between each of the word. So slow, monotonous speech, that's depression. Rapid pressured speech. In many a patient, if some, I will give you some videos of MSc in the group tonight, and you will see how many a patient talks. It will be like a rapid pressured speech. The patient will talk excessively loudly. So you have to comment on how is the speech of the patient. Normally, if the patient is talking normal tone volume, we say his speech is normal in tone volume or rate. Or if slow monotonous, we will say he is speaking with a slow monotonous speech. His speech is rapid and pressured. In depression, you can also say that taking pauses in between. Many a patient will not answer your question appropriately that you can comment. Psychosis patient will have some disorganized speech, or sometimes they can be normal also, but disorganized means whatever they are trying to say, you cannot understand anything. So that's psychosis. So next thing is commenting on the speech. So you have got A, you have got S. The next one is your emotion. Emotion, you have to comment on mood and affect. So according to the patient, his mood is low and the affect I observed is congruent with his mood. What is affect? Affect is how you can see the patient mood. If you see that a patient is sad and when you ask, how is your mood today? Or how is your mood nowadays? Patient say mood is low and patient actually seems to be in a low mood, then only you say that yes, the affect I observe is also congruent with his mood. So mood is like how the patient is saying, and affect is what the examiner or you observing in a patient. Clear? Next, P, perception is hallucination. We will discuss how to take the psychosocial history and then you will see how to ask questions to find these things. Perception is dependent on, you will ask like, do you see, hear, or feel things that others don't? So see means visual hallucination, hear means auditory hallucination, feel means tactile hallucination. So perception for hallucination. So you have got accept. Now 2T, thought form, thought content. In thought form, again, it depends on how the patient is talking with you. If I am answering your questions properly and talking in normal, like a normal person, then my thought form is linear. Linear is the normal thought form. There are other thought form. One is loosening of association, flight of ideas, tangentiality, circumstantiality. What are those? Loosening of association is a characteristic of psychosis or schizophrenia. In loosening of association, there will be no association of whatever patient is saying in your answer. Like you ask a patient, how's your days going on, John? And the patient answers, my name is John. My mother is in the movie. I should read a book. Oh, that pencil is really nice. Do you want to go swimming? So in each of the sentence, there is no relationship between each sentence patient is saying. That is loosening of association. And you ask the patient, how is your days going on? And patient's first answer was, my name is John. And patient never ever answered your question. That is also called tangentiality. Like when you ask a question, patient goes in a direction, goes and goes, never ever answer their question. That's tangentiality. Circumstantiality, when you ask a question, patient goes in various directions, but eventually answer your question like a circle. Circumstantial is like a circle. You ask John that, John, how is your days going on? So your cycle start from here. And John is saying, my name is John. My dad is in the movie. Oh, my mom is going for swimming. That play, it was very nice. Yeah, my days are going all right. So the lastly patient answered your question. Okay, that calls circumstantiality. So these are all characteristic of schizophrenia, loosening of association, tangentiality, circumstantiality. Another one is the flight of ideas. Flight of ideas is characteristics for mania. What happens in mania is There will be also loosening of association, but each of the sentence patient saying will have some relationship, like, how is your days going on, John? Yeah, doctor, my days are good. All the days I'm sleeping. I don't need to sleep in the night. I feel like the nights are really crazy. Yeah, that man you can see in the street, that's really crazy. That he used to throw some bricks into my head in the last day. So what I'm saying, my speech is very loud. I'm talking excessively. I'm talking like I'm jumping from one idea to another idea. But each of the sentence I am saying have some association, right? So that's flight of ideas. If you look at one of the example here, let me show you. So example of flight of ideas. I loved that movie. I'm going to watch a movie with my mom. My mom adores me. So each of the sentence, movie, then movie, mom, mom. So each of the sentence has some association. That is called flight of ideas, but the ideas will jump from one topic to another. Flight of ideas is a characteristics for mania, others schizophrenia. So you have to comment, like if mania case comes, you have to say that in thought form, patient is having flight of ideas, but there is no losing of association, no tangentiality, no circumstantiality. In MSc, I always like to give positive and negative findings. An examiner also likes that you know what you are talking about. So give the positive findings and also say the negative findings. Thought contents is your delusion. So we will discuss the delusion questions later on, so you will understand. So if any delusions are positive, you have to say that in thought content, these delusions are positive. Lastly is your cognition, insight, and judgment. Cognition is if the patient is oriented to time, place, and person. Insight, judgment, and 3R. I'm just going to discuss that psychosocial history, and you guys will know how to ask question about cognition, insight, and judgment. Lastly is your 3R. In 3R, we make sure that what is the risk of the patient, if the patient is high risk or low risk. High risk means if a patient is having active suicidal or homicidal ideation, having active hallucination or delusion, that patient is high risk. Rapport, if the patient is talking with you, answering your questions, that means you are able to make a good rapport with the patient. In many a patient, you may not be able to maintain a good rapport. Reliability, the history that was given by the patient, was it reliable or not? Remember, psychotic patient, mania patient, whatever history they give, they are not reliable. So you have to request a collateral history from a family member. All right. So you can see in here, we have discussed the MSc, how to say it to the examiner. Now let's discuss the psychosocial history that will clear up what you are missing now. So that is your psychosocial history. Like in the exam, they will give it to you like a 30-year-old patient comes to you wandering in the streets. You have to take psychosocial history and present mental status examination to the examiner. That's usually the MSc task. So psychosocial history is the first thing that you have to ask. And in psychosocial history, you will ask all the aseptic J3R. Okay. Now, in psychiatry, your first and foremost thing is asking or ensuring confidentiality. If you guys don't give confidentiality statement in psychiatry, the patient will not give you any positive information and you may fail the case. So always try to give a good introduction when you first enter into the room. Many people or many candidates follow that there is a very good line written in the Karen notes, like, um, well, whatever we discuss today is going to be confidential between you and me unless it is harmful for you or others. But I don't like this one, because everyone preparing for AMC clinical, they read, most of them who don't have a guidance, they read Karen notes and go for the exam. And in Karen notes, this one is written. And for a long period of time, the examiners in AMC know that this is written in Karen, and they don't like Karen, because it means that you are just memorizing and vomiting stuffs in the exam. No one would like that. But you should make sure that you don't sound similar to other candidates. You have to make yourself exceptional. As from the first I said, you have to sell yourself. That's the important thing, because they are not passing everyone who is appearing the exam. They are passing only people who are exceptional. So you have to make yourself exceptional. No one can make you exceptional. It's you who can make yourself like that. So ensure confidentiality is the important part. How to do that? In my way, I would say that a little, like, don't rush asking the question. Make rapport with the patient first, then go into the question. So you can say, hi, I'm Dr. Arshan, one of the doctor here. Now, if a patient is depressed, then you can start in this way. John, I can see you're really sad. I'm really sorry that you are feeling in this way, but I want you to know that we are here to help you. And you can tell me what's making you really stressed. You don't need to feel just or embarrassed with us. And I can make sure that you will not be embarrassed. You will not be ashamed in front of me. You can be totally frank with me. Whatever going in your mind, I can help you overcome those situations. I will be here with you until you are ready to talk. So, in a sad person, sometimes whatever you give or whatever you say, patient may not open up. So try to make sure that patient feel like, yes, I can share these things with this doctor. Okay, so you can say, hi John, this is Arshan, one of the doctor here. I can see you're really sad and stressed. I'm really sorry that you are feeling in that way. Please don't worry. Now that you are here, you are safe with us, and I can help you going through this situation. You can tell me what's making you really stressed. You don't need to feel embarrassed or judged. You can be totally frank with me, and I can assure you whatever I am going to discuss with you is going to be confidential between you and me. It's okay that if how you are feeling, would you want some tissue and water? I'll be here until you are ready to talk. Give some pause. Patient will be crying in front of you, um, will not maintain any eye contact, but that's okay. Just give some pause. Patient will not say anything that's happened. Then you start asking question. Like don't wait at too much time that patient will say, yes doctor, tell me what you want to ask. Sad people don't want, like, don't act in that way. So after you have given enough confidentiality and reassurance, start asking question. So John, can you please tell me how is your mood these days? Patient will say low. Now in mood, what you find out? Write aseptic. So all of you with me, I am also writing aseptic in my paper. You also write aseptic J3R, right? So appearance, you can already see what is the patient position. Patient is looking downwards, not making eye contact, seems gloomy, dressed appropriate to the weather. So you can already know what is going on. Now speech is, usually you will get in depressed patients slow and monotonous speech, right? Then emotion, already patient says low. So what the patient say, you can just write in front of the E, that low. An affect that you observe is also congruent with the mood, right? So with mood, we usually in psychosocial history, we ask 2 or 3 questions. How is your sleep and appetite? And we also ask suicidal question. Do you think life is worth living? Do you have any passing thoughts of harming yourself or others? This is just to make sure the risk. What is the risk of suicide in this patient? So format is mood, sleep appetite, suicide risk. Then go into the perception or hallucination. Before asking hallucination, say, John, I'm going to ask you a few strange questions that may sound silly to you, but please don't get upset with me. These are some screening questions I need to ask all of the patient. So do you feel, see, or hear things that others don't? No, doctor. So that is perception. That means hallucination you have asked. Then next two is thought form, thought content. Thought form, in depression patient, thought form will be linear and there will be no tangentiality, no loosening of association, no flight of ideas. So thought form, there is no question to ask. It how you are making conversation with the patient. Thought content is your delusion. Now delusion has a lot of question to ask. How you can remember? We can remember by this option called RCGGP. All right. So RCGGP, these are your main delusion. What is R? R for delusion of reference, delusion of control, delusion of guilt, grandiosity, paranoid or persecutory delusion. Very important to find out what sort of delusion patient is having. Delusion of reference, or you can start asking question. So do you think someone is spying on you or trying to harm you? This one is the paranoid or persecutory delusion. Do you think someone is controlling you? So C. Do you think people are talking about you? That is for delusion of reference. Do you think you are guilty about something? That is guilt. Do you think you have some special power? That is for grandiosity. So that is your main delusion. There are other delusion like, do you think someone is inserting or withdrawing thoughts from your mind? This is thought insertion or thought withdrawal. Do you think your thoughts are being broadcasted in TV, radio, or newspaper? So that is thought broadcasting. So in psychotic patient, you have to ask all these delusion question. But if it's a depression case, you will already understand. So you don't need to ask all this. You can ask, you should ask, obviously, do you think you are guilty about something? Because sometimes depression patient usually feels like they are guilty about something. So you don't need to ask all the delusion question in a depression case. But if it's a psychotic question or psychotic case, you don't need to ask this guilty thing. But you should ask spying, controlling. Those questions are pretty important to ask. So delusion is very important to find out. Next is insight. Do you think you need some medical help? If a patient doesn't have insight, they will say, no, I don't need any help. Judgment, if there is a fire in this room, what you are going to do? Normal patient will say, I will run away. Some psychotic patient will say, what? There is fire in the room? Where is the fire? That means they don't understand normal, like normal conversation. They have difficulty understanding. They have concrete thinking. So that's also done. And some psychotic patient will say, I will be in fire. God will rescue me. All right. So that's pretty high judgmental people or psychotic patient. So that is judgment. Then cognition. In cognition, we look for if the patient is oriented to time, place, and person. So where are you at the moment? What is the date today? And do you know who I am? So who I am is the person, date is the time, and where are you is the place. So time, place, person, oriented. That is cognition. So you have asked about insight, cognition, judgment. Normally, if your task is mental state examination, MSc, then you even if you don't ask heads, SADMA, past medical, these things, this is fine. You don't need to obviously ask it. But if you have some time, you can ask a legal question about from this, because this is also included in psychosocial history. So after you ask cognition, you go for heads. In the heads, especially we ask for home situation and if the patient is having any stress in their life. So how is your home situation? Any stress at your home or work? Do you have enough support? Heads include many things like H for home, E for education or economic, A for activity, D for diet, S for stress, another is for sexual life or support, you can say. So you don't need to ask all these questions. I always ask home situation, stress at home or work, and enough support. That's all. SADMA, do you smoke, drink alcohol, any recreational drugs? Past medical history of any mental illness, family history of mental illness. Always in psychosocial history, try to rule out organic cause. Like, do you have any change in weather preference, hypothyroidism, any recent head injury, or any recent flu-like illness? These three usually some of the organic cause can present as psychosis or some psychiatric disorder. So change in weather preference, head injury, flu-like illness. So now this is actually your full psychosocial history. It's a pretty important to follow the format, otherwise you will feel really stressed in the exam. So first, confidentiality, mood, sleep and appetite, suicide risk, hallucination, delusion, insight, cognition, judgment, heads, SADMA, past medical history, family history, medication history, organic cause. Clear? Now, if you see that if in the exam they ask you to present MSc to the examiner, you have to ask these questions. Otherwise, you cannot present, right? So based on the history that you are asking, you have to present MSc to the examiner. Now, can I have anyone in the Zoom who wants to do a role play with me from MSKs? Just if anyone brave enough, even if you don't know anything, you can just give it a try. Dr. Humera, you want to do? Yeah, good. That's a very good thing. Let me allow you to talk. Just give me a second. I have unmute you. So can you hear me?
Yes, I can hear you.
I can't hear you properly.
You can't hear me?
Just give me a second.
Okay.
All right. So you will get 2 minute time. Sorry, you don't need to, you will get 1 minute time to just think about what you are going to ask, and then you will get 7 minute time to talk with me. Okay. So this is your station. You can see 1 minute time started.
Time starts now.
No, I will just say you that when the time starts. All right. So Dr. Homera, your time starts now. Hello, doctor. Can I check your ID, please?
Should I need to introduce myself first?
Yeah. All right, let's start again. No worries. So I will ask you that, just think it as an exam situation. So I will ask you, hello doctor, can I check your ID? You will say yes, doctor. So I will introduce you to the patient. and then you will start asking question. Okay,
Okay.
let's start. Hi, doctor. Can I see your ID?
Yeah, sure.
Well, this is your patient. Your patient name is John. You can start asking question.
Hello, John. My name is Dr. Humaira Khan. I'm here to help you. And wherever I'm going to ask you, it's totally between me and you. And like the other patients, I, 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 I will give you some good advices, and that will help you in future. And you can tell me whatever you want to tell me, and I will definitely help you.
No, I don't want to talk, doctor. I just, I just killed, killed a cat. You know, the cat. It was so puffy, and I just killed that cat in the surgery. I'm a murderer. I just don't want to live this life. I want to kill myself. Just let me go.
I can see, John, you are very you feel really depressed, or you don't want to talk more. But I will definitely help you. Um, do you like to have some water or tea? Can I bring something for you?
It's all right. It's okay.
If you allow me, can I ask few questions? If you, whenever you want to talk, just let me know. I can help you. I can hear you.
Yeah.
It looks like you are very in a low mood and you don't want to talk to me, but I can assure you I will help you if you tell me everything just like I'm your friend.
Yeah. What do you want to know?
But I can assure you, you can whatever you feel, just discuss with me, and I will definitely help you.
Yeah. Yeah. Okay.
Is it fine? I can ask you a few questions.
It's okay, doctor. Ask.
Okay. First tell me, how do you feel now?
I'm not feeling good. I just don't feel good.
I mean, what type of do you sleep last night? Uh, are you taking your meals regularly?
I can't sleep. I just think all the time about that cat. I can't sleep
So, since how long you can't sleep, and why are you feeling so low? Can you share
because
something with me?
I said, doctor, that I killed that cat. I'm a murderer.
Don't think like this, John. I can help you if you tell me some few more questions. Do you think about yourself you are a murderer, and anytime you like to harm yourself?
Yeah, I just want to kill myself
How many times did you feel like that?
all the time.
All the time? Did you try to harm yourself anytime?
Yeah, yeah, I just tried to hang myself.
Do you feel somebody is controlling your mind, or do you mm, I mean, do you hear any noises?
No,
No. Maybe these type of questions feel silly for you, or you see, but I need to ask few questions more. uh, what about your daily routines? Any support from your family members?
yeah, my wife is quite supportive.
She's supporting. And
Yeah,
what other things normally you do all the day with your family members? Do you have kids? Do you enjoy life with them?
I don't enjoy anything now. I just want to kill myself. Just want to end this life.
Okay, that's all, doctor. I can ask these questions.
You finished? You present it to the examiner, what you have asked.
Okay. Present to the examiner. Um, so in the beginning, when I'm going to present the examiner, I need to introduce myself again.
No, you can just say, Doctor, I would like to present the MSc of my patient.
Okay. The doctor, I would like to present my examination and what findings I need to tell you about the feeling and mood and sleeping habits of a patient. And there's a few positive things I noticed because the patient was telling me he couldn't sleep and he likes to kill himself. And there's a continuous thoughts about these. And that was a alarming sign. And we need to uh, give something, the treatment which helps the patient. Other than that, he was telling me about the support from the family members and so these are all the things which I noticed during the examination.
All right. Anything else?
uh, Anything? No, that's all.
All right, doctor, no worries. Thank you, Dr. Humera. It was really nice. I assume that you just started your preparation, and based on that, it was really good. Okay,
Thank you.
I'm just muting you. Just
Okay.
muting you. Just yeah. No, see that Dr. Humera, I think from her starting and from her discussion, I think that she just started her preparation for AMC clinical, but how she is asking the questions and how she's doing good. From my view, if I was in her position, I would not able to do this much what she has asked. So in the just we have just taken that class, and from that perspective, how she has performed, it's nice. With more preparation, with more discussion, she will be doing great, I hope. So let's just say that what should be actually done in this case. So as this is a depression case, right? We have to ask all the question like you have to perform the MSc. Perform MSc means you have to ask all those psychosocial history. So initially, like it's okay that you should give reassuring statement, but don't waste half of your time just to give reassurance. You can start your asking question if they because when I am saying yes doctor, so you can start asking question. You don't need to take permission again that should I start ask your question. Like your thing is you will say in that way, hi John, this is Dr. Arshan, one of the doctor here. I can see you are really stressed. Now you see my tone is kind of vibrating so that I'm trying to show to the patient that I'm also sad for the patient. I'm really sorry that you are feeling this way. I can see you are really sad and stressed. Please don't worry. Now that you are here, I will try my best to make sure you are fine. You don't need to feel stressed. You don't need to feel embarrassed or judged. You can be totally frank with me, and I will be here with you until you are ready to talk. You will be fine, trust me. I can assure you, whatever you are discussing today is going to be confidential between you and me. Now you said whatever you want to say. So this is a kind of now psychiatry is acting. Patient will act, you have to act also. So you have to be a good actor than the patient if you want to pass the case. So act like the patient or role player so that they don't lose you. So you have to lose the role player. That's the main thing. Then like give you some pause. If the patient will start crying sometimes if in a depression case, so give some water, tissue. Now always when you enter into the room of psychiatry, always try to look in the room where is the tissue and water. Okay, so that during that this time you don't need to look around where is the tissue, I cannot find the tissue. Don't do that. So try to always locate where is the tissue and water in the exam hall. It's important. After you have done that, then take a pause and then you start asking. You don't need to take permission again and again. So you can say, can you tell me, John, how is your mood these days? How is your sleep and appetite? Just one question. Don't ask detail. Like if sleeping problem, don't ask how long. because you don't have that much time. Depression patient will be so much slow that you will try to kill yourself otherwise. So you will say, please go on, please go on, like that. But they will be really slow. I was pretty fast with Dr. Humera because otherwise she could not finish the in time. But in exam, if I am taking your exam sometimes, then you will see like how the role player is. They will like so slow in depression, so much slow. So already you will lose many times. So don't lose more time asking detail. Then go for the suicidal question. Do you feel life is worth living? Yes or no? Now in here, you don't need to ask like, do you have any passing thoughts of harming yourself? Because already you know, but the patient was trying to hang himself, and that's the question, right? So you know patient is having suicidal risk. You can ask, do you have any plan of suicide in the near future? And if yes, then do you have any plan for that? And do you have any access to any weapon? Now, these are usually psychosocial questions. In MSc, if you just get that if a patient is having suicidal risk, that's all right. You don't need to go in details. Then ask hallucination, delusion, insight, cognition, judgment question. Then you present MSc. You will thank the patient and then turn to the examiner, say, examiner, I would like to present mental state examination of my patient John, who presented with a history of trying to hang himself with a rope since a cat was died during a surgery. In terms of appearance and behavior, he was dressed appropriate to the weather. He was cooperative, but he was not maintaining eye contact with me throughout the examination. He was sitting in a stooped posture. Okay. His speech was slow, monotonous. According to him, according to him, his mood was low, and the affect I have observed that was congruent to his mood. In terms of perception, he doesn't have any hallucination. Thought form was linear, but there was no tangentiality, circumstantiality, or flight of ideas. In terms of thought content, he is having delusion of guilt because he thinks that he he's a murderer. And now you have to ask the question actually, like then the patient will say, yes, I feel guilty about killing the cat. So you have to say, yes, in terms of thought content, patient is having delusion of guilt because patient thinks that he killed the cat and he is a murderer. In terms of insight, patient insight is low or insight is poor because he doesn't want to live and he doesn't need any medical help. Cognition, he was oriented to time, place, and perception, time, place, and person, and the judgment was poor because patient when I asked about that, what you will do if the room catches in fire, patient says that he will stay here. So you can say that if you have time, otherwise you can just say insight is poor, insight judgment is poor, and patient is oriented to time, place, and person, sorry. And then lastly, 3R. Patient is of high risk because patient is having active delusion and also active suicidal ideation. I was able to maintain a good rapport with my patient, and the history that patient gave to me is reliable. That's your mental state examination, how you present it to the examiner. All right, guys. So this is how you should present. Otherwise, if you don't follow aseptic J3 here, if you just say scatteredly, most of the time they will not pass you. MSc case is very important, and in here, if you just make a little mistake, they don't pass you. It's a very important and difficult case to pass because even a single thing you miss, they can fail you. Like if you don't say delusion of guilt in this case, they can fail you. If the role player doesn't like your approach, they can fail you globally. Okay, so important, these cases are important for making format. So these cases needs extensive role play with your partner. So these were the positive finding. I just said all the finding in here. Any question from this case, guys? Have you understand how to take the psychosocial history on MSc? Dr. Nadia Islam, how to ask M size cap? M size cap is not important in here because you don't need to say any diagnosis. If any time you have to say diagnosis, like take psychosocial history, give diagnosis and differential. At that time, you have to ask all the M size cap question. So what is M size cap? M is for mood, S for sleep, I for interest, G for guilt, E for energy, C for concentration, A for appetite, P for psychomotor agitation or retardation, and S for suicidal ideation. That is M size cap, right? Just let me write it so other can understand. This is for depression case. Like if you are ruling out depression in any patient, then you have to ask all the depression question. But for MSc of depression, you don't need to ask all these questions because you just need to present MSc to the examiner. So how is your mood these days? How about your sleep and appetite? For interest, what you can ask is like, do you enjoy the things that you used to enjoy before? Do you feel guilty about anything? How about your energy and concentration? Or you can ask, how about, do you feel lack of energy? Do you feel lack of concentration? How about your appetite? You can ask sleep and appetite all together. Do you think that you have quite slowed down recently? That is for psychomotor retardation. S for suicidal ideation, that's already you are asking. So usually if diagnosis of depression you need to make, you have to have at least 5 of these M-site caps to say that it's a depression. So in that case, you will ask this question before going for the hallucination delusion. So let me show you. So before hallucination, you will finish your M-site caps, just changing the format. Yeah, Dr. Hafsa, you can ask mood and sleep in MSc, but it's not a mandatory thing because you are not commenting on sleep and mood. Obviously, you have to ask, but sleep and appetite, it's not a part of MSc, but it's just like one question. It's just before asking suicide, asking one question is seems good to me. That's why. But if you miss that, it's totally fine. So we discussed the first MSc case. Now we will discuss another one about your psychosis. Anyone interested to do a role play? Anyone who already started preparation? I know that many of you are here who already knows these things, right? So any of you who wants to just do a role play, it's a pretty important for your exam. Dr. Afrin, yeah, please come online. Let me unmute you. All right. So Dr. Afrin, can you hear me? Hello? I have unmute you.
Okay.
Yeah, okay, good. So this is your case, doctor. You have got 1 minute time, and then you have to just your task is to take further history and present MAC to the
Mm-hmm.
examiner. Just up to this, not others.
Okay.
All right, doctor. Can I check your ID, please?
Yeah, sure.
So this is your patient. Your patient name is Smith. You can start.
Hello?
Yes, doctor. You can start. Your patient name is Smith.
Okay. Hello, Smith. I am Dr. Afreen, one of the HMO in the emergency department here.
Yeah, yeah, doctor.
Smith?
What
Yeah.
happened?
Yeah. Okay. I have, I guess you have come here for your antipsychotic medicines.
No, doctor. I haven't come here. The police, the bloody police, just took me from the street. I was just walking in the street, and that stupid police just brought me here. I don't know why. Can I go? Just because it's just a lot waste of time of yours.
Okay, I'm so sorry, Smith, about that. But could you just hold on for some time? And
Why? Oh,
I would help you with this.
yeah, whatever. I don't need your help.
Okay. Okay, I can assure you that you would be home in no time, but you would have to just answer a few questions of mine before that, if that's okay with you.
I don't think so. I just, like I'm just a normal person. Is the police supposed to bring everyone walking in the street to the hospital? The hospital will be like full of patient at the time, right?
Yes, Smith, I'm really sorry from their part. But let me help you with this. I don't know what had happened, so maybe I can help you and get you home sooner.
Yeah, what do you want to do?
Okay, Smith. Before we start, I would like to tell you that whatever we speak now, it's going to be between us. And I will do everything to help you get whatever you need. Okay, John? Okay, Smith?
Yep, sure.
Okay. So can you tell me about your mood?
I'm fine. I'm feeling okay.
Okay, and how is your sleep and appetite?
All right.
Okay. Do you think your life is worth living?
Yeah, obviously. I think so.
Okay, okay. I know some of my questions will make you feel that they are very silly, but please bear with me and answer a few more.
Mm-hmm.
Okay. Do you see, feel, or hear things that others don't?
What do you mean? Do you think I'm crazy? Some kind of crazy, stupid people?
No, Smith, absolutely not. That's why you don't. Okay. Do you feel guilty for something?
No, why I will feel guilty? I'm the messenger of God. And God is giving me messages to help other people. So why I will feel guilty? I'm really happy with myself. And the other people,
Okay,
you
so
see the other people in the street, they
Mhm,
are really jealous
mhm.
about me. They are really jealous. They are talking about me that, see this guy, he is the messenger of God. So they're really jealous. And I don't like those people.
Okay, so you feel that you have special powers?
Yeah, I'm the messenger of God. Who has this power?
Okay. And do you think someone is inserting or withdrawing thoughts from your mind?
No,
Okay. And do you think your thoughts are being broadcasted in TV or radio?
no.
Okay. Okay. Do you think that you need some medical help?
Why? If I'm the God of if I'm the messenger of God, do you think I need a medical help? That's why I said
Okay,
it's a
Smith.
total waste of time, doctor. It's totally waste of time. You could
Just
save
bear with
other
me. Just,
patients in this time.
yes, yes, Smith. Just 2 minutes more and it'll be done. Okay. So if there is a fire in this room, what would you do?
Nothing. Fire cannot touch me.
Okay. And where are you right now? Could you tell me
In
that?
the hospital.
Okay. And what is the date today?
It's I think like, is it Friday today?
Okay. And do you know who I am?
Yeah, you were the doctor.
Okay, Smith. Okay. And how is the situation in your home?
Yeah, I don't have any home actually. I'm living in the street. I'm doing good.
Okay. Do you smoke or drink alcohol?
Sometimes.
Okay. Okay, Smith. Can I just get back to you after I speak to the examiner?
Sure, doctor.
Yeah. Hello, examiner. I would like to present this Smith's case.
Okay.
Okay. He is dressed appropriate to the weather, well groomed, not very cooperative, maintaining eye contact, and little restless. His speech is normal, rate, volume, tone, and his mood is okay. His affect is congruent to his mood. His he does not have any hallucinations, but yeah, and his thought form is linear. He has a delusion of grandiose, and cognition is okay. Insight is impaired. He has no insight actually, and judgment is impaired, and he is at high risk because he has
Okay.
um okay, no, he's not at high.
Yeah,
Is
go
my
on.
time up?
Finish the case. Yeah, finish the
Okay.
case. It was good.
And um he has active delusion, so he is at high risk, and he is I would also like to take history from the relative because his history is not very reliable. Oh yeah, yeah,
Yeah, it
that's
was
bad.
Miss Repo. It's all right. Yeah, it was
Oh, okay,
good,
sorry.
Dr. Afrin. It was really good. I'm really
Okay,
happy how you handled this situation, handled this case. It was like perfect, I would say. So
okay,
just let me
thank you.
yeah, let me mute you. Okay, so it was really good. As you all of you have seen that that's how you should present MSc and how you should ask question in the exam. So just like this, you should make sure you are confident enough, and patient will be really annoying, more annoying than me, that I can assure you. So and patient will try to divert you and everything. So make sure, also Dr. Afrin, if you like start question, immediately try to give confidentiality statement so that you can move into asking question. Before, like if you ask that, can I ask you a few questions? Patient will say no. So at that time, just politically give the confidentiality statement. So you have to be many person in the exam, so that the patient comes and they can give your and they can answer your questions actually. Okay, you said appearance, all right. The speech was normal in tone, volume, and rate. You can also say the negative finding that there is no rapid pressure speech or slow monotonous speech. Emotion, in here, whatever the patient will say that, do you think, how is your mood these days? Patients, I said my mood is good. Okay, so you have, or if whatever I say, you have to say that yes, according to my patient, his mood is good, his mood is fine, his mood is all right. What the patient word you have to say. And the affect, in a psychotic patient, if they say mood is good, it's not good actually, it's a disturbed. So you can say the affect I have observed, it's disturbed. Perception, now in here, remember this, in this case, sometimes patient will, in one point of discussion or asking question, they will give it to you that yes, he is a messenger of God, everyone is jealous of him, like this. So at that time, as he is a messenger of God, most likely God is giving him some message, right? So most likely he's hearing something. Maybe initially patient may not understand you what you are trying to ask. Then if you get that yes, this is a messenger of God case or something related to that, again ask, do you see or hear God? Is the God giving you some message? Then sometimes patient will open up, they say, yes, God is sending me message to save all the people, to good, to do good to all the people. So obviously patient is having some auditory hallucination also. If auditory hallucination positive, ask, can you see God also? No. So that's a pretty important here. You make sure that if any messenger of God or anything like that comes in the exam, you should ask, like, can you hear, or do they give you any message? That's important. Thought form was linear here. According to this here, you can give that there is no tangentiality, circumstantiality. The negative findings are pretty good, because it's always seems nice that yes, this examinee knows what he is looking for. Then thought content, in thought content, delusion of grandiosity was there because patient think he is a messenger of God. Also, if they say that others are jealous of me, they are always talking about me. Two things, jealous of me is also included in delusion of persecution or paranoid delusion. So it's a kind of delusion of jealousy, but it's a subtype of persecutory delusion. So you should say that there is also delusion of persecution and delusion of reference, because patient thinks that everyone is talking about him. So whatever you say, justify. That will save you in the exam. That you are thinking that patient is having delusion of persecution because he's thinking everyone is jealous of him. He's also having delusion of reference because he thinks all people are talking about him. So justify what you are saying. Then inside judgment was poor, cognition was all right, patient was high risk because having active hallucination delusion, and I was able to maintain good rapport with the patient, but the history given by the patient was not reliable. So I would like to take a collateral history from the police. Remember, whoever bring the patient in the hospital, you ask collateral from them. Okay, and you don't need to give diagnosis. Remember, if a present MSc to the examiner is a case, you don't need to give diagnosis, you just finish in the risk rapport reliability. Clear, everyone? So this was the exact case. So we don't need to discuss this one because whatever is here already I have discussed. There was another case from MSc, which is a MSc video case of young man think his mom has sexual relationship with his uncle. And you have to present MSc to the examiner. So they will give you a video in which one examiner and a role player will be talking, and they will give 4-minute time to watch the video, and then you have to explain the MSc to the examiner. This case was like that he was well dressed, well groomed, everything was all right, but he did not maintain eye contact. He was looking at the floor on and off, looking worried. Regarding his speech, it was normal. Mood, he said he was worried. Affect was congruent. Perception, he denies any visual or auditory hallucination. Thought form was linear. Now, only positive finding that you will get is the thought content, that he is having some daily obsessional thought as he thinks that his mom is sleeping with his uncle. He also said it's impossible, but he cannot get rid of it. Whenever this thought comes in his mind, he needs to stand up and move around. So he's also having the compulsion. So in thought content, both delusion and obsessional thoughts will be there. So in OCD case, they will have obsession and compulsion that will be in the thought content category. So what is the obsession here? He thinks that his mom is sleeping with his uncle. He also thinks it's impossible. That means he knows that it's not right. So he has insight. And whenever this thought comes in his mind, he needs to stand up and move around. That is the compulsion. Regarding the insight, it will be intact. Others will be all good. Just having this thought content will be the positive finding in the exam. Okay. I guess we will finish here today. There is another case of MSc cockroach. We will discuss it in one role play session. That we are going to have some role play session in the future. So I will keep this one in the role play session so that you guys can prepare yourself the MSc, and then any one of you can do this cockroach case with me. Not today. That's all about your MSc actually. Not much comes from here. If you can finish this MSc, then you are ready for the exam. But make sure that you don't get confused in the exam when patient will try to make you crazy. Okay, so you have to be very calm and confident, and that calm and confidence, that behavior comes with repetitive role playing. So make sure you have a good study partner, and make sure you do a role play every day from the start of your preparation to the end of your exam, every day. So thank you all for today's session, and you guys made this session successful, because I was not hoping that any one of you will come and do the role play. I really thank Dr. Humaira and Dr. Afrin. It was really nice that you came up when I asked. Thank you so much for that. And all of you, thank you so much for joining today's class. I hope you guys enjoyed the class. Just before you go, I would like to share you the information about the upcoming course, if you guys are interested. Now, I think all of you has gone through our Facebook group, as well as we have a website also. The link you can find at the course details in the group. So you can go through all these things, and then you can make your decision that if these things are helping you or not. I know that many of you may not need any tutor or mentor to pass this exam, but I would say, like, sometimes having a good tutor or good guideline can make you save a lot of time. All right, and can make you confident enough to go for the exam. That's important. I think very important to have someone beside you who is working in your interest. Now we will have some few session in the next few days. So I will just give you some update about some role play session, And okay, so I will give you some information about the role play session, and yeah, this we will do some role play about the recent cases that can come in the exam. And our course is starting from 27th of May. It's a 5 months course. We take class 3 days a week. Saturday and Wednesday is the fixed most of the time, unless we give you a fixed schedule. Usually, starting time is 8 p.m. to 10:30 p.m. Sydney time. We always make that class like we will do role play initially, then at the end and in the middle we will discuss the cases. The good thing is that we don't want you to role play the cases that we are discussing today. So whatever we discuss in the today's class, we will do role play in the next class so that you can prepare yourself and then do the role play with me. We do all the theory. All the theory means every theory that can come up in the exam, we will cover. We will try to do some 1 year recent sample questions so that you know what are the important cases. We will also take mock test in every month. And the one thing that is important that we are trying to make some extra role play session every week with some mini mock test so that we know that how you are preparing, how you are studying. So just to make an assessment with you. Now, the one important thing is the physical examination. You guys should be very, very good with physical examination, and you should prepare with face to face with your partner. Now, we have a plan to do that face to face in any center. So we already have a center in Sydney. So if we get lots of students from Sydney or other areas, so we can do a face to face with mannequin. We can try to do that. So we are trying to find it out. But for recent COVID situation, it's not been done at the moment. But we are in the process of that. You will get all the recordings and the course materials in the software. So once you are in the software, you will get it for the lifelong time. So you don't need to like resubscribe with us. Once you are with us, we give you the subscription for lifetime so that you can prepare yourself until you pass the exam. We also are trying to take a model test for all of you at the end of the course. The online one will be free. After this COVID situation is gone, there will be a face-to-face physical examination with 16 stations so that we can make you totally prepared before you go for exam. That will be only for people who are going for the exam recently, not for all. Okay, so that's all about our course. You can go through our website and make your informed decision. I'm not saying that you should make decision just based on one class. I will give you 2 weeks free class with me so that you can take classes with me with the course students and then you can make your decision. Within 2 weeks, if you feel like this course is not helpful for you, you can take total refund and then we are good. All right. So this is all about our today's class and also the course. I hope you guys enjoyed the class, and I will be really happy if you guys give some review like how this class was and how we can improve our class and what you really want from our course. So that will help us to make an informed decision and make a 5 months routine that this is what our candidate wants from us, and we will try to give it to you whatever you feel that is important for your exam. All right, so that's all. Do you guys have any question to ask? You can ask here. Anything related to exam, anything related to course. Those who are in the Facebook, let me just check the comments if you haven't checked it. Yeah, Dr. Nadia, you don't need to ask organic cause in MSc, right? Is history reliable here? No. History is never ever reliable in psychosis or mania case. The books that are essential for your exam, not much book for AMC clinical. For AMC Clinical, I would say just buy you can buy the AMC handbook for clinical. That's very important. You should obviously read that. Others, I don't think any other books are important because we will provide you all the notes, and usually the notes are the most important, and these are the books for you. So just buy, or even if you can read the PDF, that's all right. So if you can read the PDF of AMC Clinical Handbook, we will give it to you also. That's okay. Some people also buy Teleo Corner physical examination book, but I don't think it's totally necessary because we discuss all the physical examination that can possibly come in the exam. Any other question? Okay, then, so yeah, we have a PDF of handbook. We will give it to you. I think I can upload it in the group also, that in that case, you can start preparing yourself. Okay. Thank you all for joining today's session. Keep an eye to the group for the next role play session. We will take role play session every week. That's our plan. It's a free role play session. I'll be really happy to help you going through this situation. Now that it's a real tough situation, in Australia it's good, but some of you are in some other countries where you may not be able to go out from your home. So try to be safe, guys. That's the most important part. So try to be safe enough so that you can appear in the exam and make your dream fulfill. All right. So be safe always in this situation. When the situation is gone, everything will be all right like before. And use this time. Okay. Don't waste this time. This is a good time that you can prepare yourself with all your time. You don't need to go anywhere. Have a good night's sleep. Bye.